I'm very happy to introduce friend and colleague, Dr. Venkata Koka, who is an ENT and sleep specialist and maxillofacial surgeon from the Department of Sleep Medicine from Antoine Beclair Hospital in Clamart, just outside of Paris. Thank you very much for being here today, Dr. Koka.
Yeah. And I thank everybody here, and also I thank very much Dr. Shannon Keenan and Mark Muller for having invited me here to exchange my ideas with you. I'm talking about impaired pharyngeal dilator muscle function in OSA. That's a phenotype for new modalities of treatment. I generalize a little bit on the phenotyping and talk about the muscle function. I have no interest of disclosures, conflict of interest, and obstructive sleep apnea is increasingly common disorder with heterogeneous many phenotypes. The treatment nowadays, in the past also, it's kind of limited to anatomical interventions. And 50% of the CPAP patients, they fail to adhere to the treatment and use the CPAP less than 4 hours per day and less than 5 days per week. The other interventions like weight loss, mass, and surgery, we get unpredictable results if we don't phenotype the patient. That's why a phenotype targeted approach with new modalities, I will talk about them, should improve the success of our treatments. These are the phenotypes. This impaired anatomy or the collapsibility is very important. A minor or a major or moderate anatomy is necessary to drive the process or the pathogenesis of OSA, to collapse the airflow. And this dilator muscle function is very important because if you take the obese patients, all the obese, even they have passive collapsibility, they are not getting OSA. And also, we are not having OSA in all stages of sleep. So there are other non-anatomical phenotypes are protecting or making more severe the disease. This is the dilator muscle effectiveness. If it can compensate and it can increase the airflow, when there is poor muscle responsiveness, it can decrease the airflow during the obstruction. These arousal thresholds and ventilatory chemosensitivity, they cause instability and arousability and make things worsen. When we talk about impaired anatomy, it's not really it's not a static anatomy. It's a dynamic. It's collapsing. This a functional anatomical impairment is measured by a Pickett technique, and you all know. And we compare this Pickett against HI. This Pickett is positively correlates with the severity of AHI in supraatmospheric or atmospheric or more than atmospheric pressures. If you look at the table here, I think below -5, there is no OSA because most of the patients are protected here. And above +2, you have the severe OSA and with wide variance also. And between -5 and 2, you have moderate, mild, and also normal people. So at a given predisposition to collapse, we can't know how much the severity the disease is. That's the reason why we have to look into the other phenomena around. This Pickett, and this has given a concept of Pomscale categorization. This Pickett, if it is more than +2, this is more severe impairment, and this is scale 1. Here the anatomical impairment is more important. In Pomscale 2 is moderate anatomical impairment between -2 and +2, as I told earlier. And in minor anatomical impairment, you have less than -2. It's a minor anatomical impairment. And 70% of all these patients have one or more of the non-anatomical traits. If you look at the Pomscale 3, minor anatomical impairment, we call it minor. It's a mild OSA in loose terms. That 100% of these can have one or multiple non-anatomical traits. And in moderate also, 1/3 can have no non-anatomical traits, but 2/3 can have one or two non-anatomical traits. If you treat only for helping removing the obstruction, impaired anatomy, you cannot be successful unless you look into these non-anatomical traits. These OSA traits are measured using repeated CPAP, dials up and dial downs. And when the CPAP, we treat the CPAP, we treat the OSA patients or normals, anybody with a CPAP, therapeutic or optimal levels. When you drop the CPAP to subatmospheric or atmospheric in the night, what happens? There is a ventilatory, the ventilation can decrease at this lowest ventilatory drive, because at CPAP, the ventilatory drive, there's no minimum or negligible ventilatory drive. With a sudden drop, the ventilation descends down with a eupneic ventilatory drive. At different pressures, we can do that, and we can extrapolate, and we can know the peak rate. Anyway, at a time when you leave the patient in that subatmospheric period, there is increase in the CO2 and also the respiratory drive, increasing the recruitment of the muscle, so increasing the ventilation. That's called muscle responsiveness, muscle gain. And when we pull up, when we come back to the optimum levels, optimum therapeutic levels, there's a ventilatory response to the ventilatory disturbance. That's loop gain. We need to calculate everything, especially the loop gain, to know measure all the phenotypes. And arousal threshold is level of the ventilatory drive to give that arousal, that results in the arousal. Here it's an interaction between the three phenotypes. It's very important because when you take a passive upper airway, it's a passive collapsible airway, then there is a upper airway muscle responsiveness. This starts from the passive ventilation there when we drop, and then this increases. Then you see this line, it goes up. This is the muscle response. This is the achievable ventilation when there is a drop, rather. Here, this is some demands of ventilation is that it decreases with the decrease in the ventilation. This is a ventilator drive necessary to equate the demands. Then at this intersection, you have a steady point there. If it reaches the ventilation and the ventilator demands reach at certain equate, there is no OSA. If arousal occurs before that steady point, certainly there will be OSA. And if here the arousal occurs a little later here, and there is no OSA here. Yeah, and I want to show here a much interesting phenomena. Here you have the muscle response here. So there's a poor muscle response, this line. Yeah, and here this ventilatory demand here, they are not meeting, and here arousal has occurred. This patient certainly will have OSA. Because the muscle responsiveness, it should go here. Okay, and nowadays we are doing, Mr. Scott he has developed an automated phenotyping with using polysomnography in patients with OSA, so that we can phenotype the patients out of the lab. We need not put EMG nils, and we need not do CPAP drops and dial-ups. This is a future. Within 2 or 3 years, we'll have this to phenotype all the patients at home. Here, we calculate the ventilatory drive for each breath. And this is put like this. You see the darker line going up this ventilatory drive, which increases the ventilation. With the ventilatory drive, here you have the obstruction. This is a apnea, and there is a ventilatory drive is very low here, and the ventilation drops, and then ventilatory drive increases with obstruction, increasing the ventilation until the compensation occurs, or there is an arousal. Here you can plot between this ventilatory drive to the ventilation here the V passive. The distance between, the difference between V active, the V apnea and the V passive is the impaired anatomy. And V active and the V passive, it is the muscle compensation. Here the patient has a very good muscle compensation. Then this impaired dilator muscle function, we can treat according to the phenotyping. You use upper airway muscle training, Mark has told that 50% reduction in the AHI, and you have hypoglossal nerve stimulation. This has reduced 50 to 70%, but in STAR study, it has shown that they didn't do the phenotyping before implanting the nerve stimulation, they got very bad results in presence of high loop gain. And now we are using some pharmacology like disipramine. It has increased the muscle genioglast activity and decreased the active precrete by 2 to 3 centimeters of water. This is a recent study done by Mr. Montemurro. It's a combination of axometine and norepinephrine reuptake inhibitor and oxybutydine. That's muscarinic anticholinesterase. This has done in a double-blinded crossover style, and one night with placebo and other night with auto and oxy. When we see this EMG activity, it is doubled or tripled above the baseline with the drug, and with the placebo, it was the same. And there is also very good reduction, like 63% of reduction of AHI in all the subjects. But we can't give this treatment to everybody because there are also certain limitations, like the passive collapsibility. It should not be more. Then there shouldn't be high loop gain, and also there should not be more obstructive apneas. The hypopnea to apnea ratio should be around more than 56%. So that indicates that this can be tried in mild to moderate OSA. These studies are going. We'll see what happens in future. Then let's talk about UA muscle control, upper airway muscle control. This comes from 3 areas. This is the neural drive from 6 pattern-generated neurons. The SMUs, they're divided. Inspiratory phasic, inspiratory tonic, and expiratory phasic and expiratory tonic. Expiratory phasic and tonic are at the anterior part of the tongue, and inspiratory are at the posterior part. It's evidently in this logic. And this upper airway muscle control is also sleep stage dependent. Because of the loss of wakefulness, there's a decrease in the muscle tone, but slowly, with increasing ventilatory drive in non-REM sleep, it stabilizes. When we've done a study on that, N3, the EMG diminishes from N3, the activity of the UA muscle diminishes from N3 to N2, and the REM you have very minimal. We can see here inputs, the pressure sensitivity mechanoreceptors with increasing negative esophageal pressures, intrathoracic pressures, the EMG must increase. But it doesn't happen always. EMG is not translated in terms of airway opening sometimes. Here you have the positive correlation, as you see, with EMG and epiglottic, negative epiglottic pressures, and 1/3 of these OSA patients, they have absent or minimal EMG activity. These chemoreceptors by hypercapnia and hypoxia, you all know that. I'll show a few examples of this. This obstructive apnea here, you see here, there are respiratory efforts, and this muscle recruitment is very poor. As you see, EMG is not increasing, and the effort is terminated by an arousal. This is poor muscle responsiveness. And here, in contrast, you have very good robust muscle responsiveness to the obstruction, but this is not sufficient enough to dilate the upper airway, and it terminates with an arousal. So there should be an equation here that the muscle responsiveness should be translated to muscle effectiveness. So there's a problem of sensing or problem of action of the tongue or upper airway dilators. That the other functional, we told the functional part, we got to know the structural elements, why this EMG activity is not translated to opening, airway opening. Here, this is everybody knows this because there are two types of muscle fibers, type 1 and type 2. Type 1 are slow contracting, oxidative, and type 2 are anaerobic, and they're fast contracting and less endurance having. When you take a PET scan, in the above you have A is OSA patient and B is a normal control. There's much more uptake, this glucose uptake in the B, there is less uptake in the A because the type 2 fibers have less GLUT4 and hexokinase. It's the transporter of the glucose and hexokinase activity. And when we're talking here, the endurance, we'll see this is the study done by Danny Eckert by calculating the protrusion force. Then in OSA patients, the protrusion force is much more than the controls. It's evident because the type 2 fibers are slow contracting, they're adaptive. But the endurance, they're lacking the endurance, the easily fatigability, and this endurance is halved in these patients. Then we have to move further because the protrusion of the tongue is not enough to test because the whole tongue should move. When there is, in sleep, that tongue moves upwards. It should not be below, or it shouldn't come forwards with every breath. Then that's why this is the muscle function as measured with tungsten endurance by IOP. I think it's a very good instrument. I use it and sometimes and often. And we measure the anterior tongue strength. It's around 60 to 65. It can go more to 70. I'm a little bit very reserved. I put it 65 because of my age. And this posterior tongue strength is 5 to 10% lesser than the anterior part. And this normal endurance values, the patient can retain the maximum, half of the maximum strength for 15 to 30 seconds. But in OSA people, there are no values, there are no studies, profound studies done on that. We can't give certain, some cutoff values. This low endurance is less than 10 seconds. We can say it's low endurance, but in OSA people, it's evident that we, by ASM classification, an event should be at least for 10 seconds. And then the poor muscle function, we have been talking about because there is a fat content and the fat and the tongue volume are significantly correlated with AHI. These are the two matched BMI. They have equal BMI. And one is having OSA on this side, you have a large tongue, large fat content, and here you have less. And here, the fat deposition is very particular. We don't know why. Because it deposits in the mid and the lower posterior part of the tongue. It can crowd up the airway when the airway cannot move. We can see the motions of the airway a little bit later. There is also, because increased viscosity and decreased stiffness, they also increase the HI, and there is reduced contractility, there are neuropathic changes. This is a great study done by Mr. Felicio. He has observed from the soft palate and uvula specimens after UP3, and certainly he has identified certain fibers. There's preferentially in the type 1 the type 1 fibers as necessary. That the type 1 fibers, they are empty of desmin and dystrophin, they're negative or they're abnormal. And these fibers are mostly found in patients, snoring patients in OSA rather than in controls. We thought that it could be a vibratory trauma or myopathy or neuropathy or a genetic expression. Here, when compared with the swallowing, when you take this is, we can go to this slide. It's better this way. This is normal, mild, and moderate swallowing. In normal, these are all OSA patients. These are 10, 6 plus 6 is 22 patients here. And these 6 normal patients, they have less this desmin empty abnormalities, and mild have more than, it's around 57 like this here, and this is the median, and also this is much more increased in moderate. So we should know that this can increase this can also cause swallowing difficulties and so on. Then if we talk about the movements of the tongue, in normal tongue, it moves anteriorly during breathing, inspiration. And in AHI, in case of severe AHI, it should go. It doesn't move much. It's only less than 1 millimeter. And in mild and moderate, we have seen a bidirectional movements of the tongue, the upper part going backwards and the lower part going anteriorly or vice versa. When here see, this is the blank area, this is a minimal movement with increasing AHI, and the black dark area with normal movement. This is a gray area, this is the orofacial movement. Mostly it's observed in mild OSA. These are the movements. You can, concentrate here on the 3. This is next. Yeah. See here it's pushing this part here, it is pushing the soft palate upwards, the tongue. This is a counter movement. And Mark has already talked about this myofunctional therapy to OSA and not again, but I can insist that there are 10 studies, mostly done by Guilleminault, these RCTs, and 120 patients, the decrease in AHI by 50%. And also, I'm interested in, also in ESS, is very much decreased, 60%. And he has talked about, Mark also, about this. This is the CPAP adherence. Is always, this is increased in the combined group. Here is 3.6. In the combined group is 5.1 after the 3rd month. And it didn't change significantly the optimum pressures. The pressure remained the same. Here, this is very interesting, but it's old paper. I took it to show you. Because once you take the CPAP, put the CPAP, you should know what's the effect on muscle. You can measure it with ultrasound elastography. By these pixels, you can measure the stiffness with that. This is without CPAP, and after CPAP, there's no change in the stiffness. It's normal because it doesn't, it diminishes the CPAP, the ventilatory drive during the sleep. This is a very great study done by Edwards to explore the predictive factors for the failure of the mass. Here, this is he has a large anatomical impairment here. V apnea to V passive is quite large, and you put a manual advancement device, or you can do a surgery to go up, and the upper airway gain hasn't changed. There's no effect on the upper airway gain because it's only decreased the respiratory load on the muscle so that it can react with what the muscle recruitment the recruitment it has. So we can change by these conventional treatments the muscle gain. We can change the loop gain, but not the muscle gain. There is something we need necessary, that is the myofunctional therapy, because it not only changes the pharyngeal muscles, it can also increase the strength, remodel the upper airway, and also eliminate the incoordination between the pharyngeal and peripharyngeal muscles. It's very important to understand the heterogeneous pathogenesis of OSA and recognize these OSA phenotypes like responsiveness, arousals, and loop gain. And MFT, as Mark told, it definitely improves the mouth breathing. It reduces the mouth breathing, shallow, and improves the swallowing. In the reduction of the mouth breathing is positively it helps the CPAP adherence also. So employ myofunctional therapy alone when they're when you call the type 3 palm type, some class 3 rather, when they're only mild OSA with alone when there is a muscle gain is less, muscle responsiveness is less, or in combination it exists with low aerosol threshold, upper airway distance like that, or else you can treat high loop gain with oxygen or acetazolamide. And also in moderate and as OSA, when we have the phenotypes here, muscle responsiveness or other, especially muscle responsiveness, we phenotype it, we have to use it with surgery or mandibular advancement devices, this myofunctional therapy, to get very good results, 100%. That's a targeted treatment. For the first line treatment, we have to define, which if you give a treatment depending on just AHI variables, it doesn't mean anything. We have to go beyond these AHI variables to treat a patient. Nowadays, we are thinking, sometimes in future, we think we can take the collapsibility variables. And PSG can identify the passive collapsibility now. It can identify the muscle responsiveness. It can identify the arousal thresholds and loop gain, and we can target the targeted treatment to these phenotypes. And I thank you very much.